Hi, everybody. Why don't we get started? My name is Richard Lane, and I'm a professor here in the Department of Psychiatry, and I'm director of the psychotherapy curriculum in the residency training program. We've recently undertaken a review and updating of our psychotherapy curriculum because of the evolving circumstances of our profession. And today's talk is therefore especially timely. I'm very honored to introduce today's speaker, who's a good friend and wonderful colleague. John Rossi was born in Manchester, England, of Lebanese parentage. He got his primary, secondary, and higher education in Lebanon and graduated with distinction from the American University of Beirut School of Medicine in 1956. He came to the University of Rochester to do his residency training, and at that time worked with John Romano and George Engel, who of course created the biopsychosocial model. John returned to Beirut for 6 years, where he served as chief of the psychiatry section of the Department of Internal Medicine in Beirut. And then in 1966, he returned on a permanent basis to the United States, where he served for 12 years in the Department of Psychiatry in Rochester in several different roles, including head of residency training. He came to Arizona in 1978 and became professor of psychiatry here, has been in several different positions, including director of consultation psychiatry and head of the residency education program, but best known for the fact that he has been head of and director of medical student education and psychiatry for the past 3 decades. Anyone who's been in John's office knows that he's received far too many awards for me to list now, but I'll just name a few. He served as president of the Association of Directors of Medical Student Education and Psychiatry. He was the first recipient of the Nancy C.A. Rescue Recognition Award for Excellence in Medical Student Education by the American Psychiatric Association in 1991. He's a fellow of the American College of Psychiatrists, the American Psychiatric Association, and the American Association of Social Psychiatry. He's been twice honored by the medical students here at the U of A as Clinical Educator of the Year in 1985 and 1987. In 2000, he was awarded the Clinical Science Educator of the Year Lifetime Award. I joined the department in 1990. And for 21 years, I've admired and greatly appreciated John's wise counsel on many issues that required delicate and nuanced judgment. Today, we are very fortunate as a department to hear from one of the most knowledgeable, wise, and beloved clinicians and educators in our field. And today, John will speak on the present and future of psychotherapy and psychiatry, a personal perspective.
Thank you very much, Richard. I had said to Kylie, whom you've seen and who organizes these things, that I was perfectly prepared to introduce myself, having been here longer than anyone else. But she said that won't do, and I think this is much better. Thank you. Yeah. Thank you very much. What I'm going to share with you is the Jim Bartlett talk. I was invited to be the Jim Bartlett visiting professor in Rochester back in last December, and to give a grand rounds talk in Rochester, where I had had my residency training and had served on the faculty. Because it is sufficiently autobiographical, I will give you the talk pretty much as I gave it in Rochester. And as I present it to you, you will see how that makes sense. I'm honored to be asked to give the James Bartlett lecture today. I was encouraged to address the future of psychotherapy. Yogi Berra allegedly said that prediction is very difficult, especially when it involves the future. It has been attributed to other people too. Since there are few reliable crystal balls in this world, most predictions become a projective exercise. People predict what they wish or what they fear. Prediction can be veiled prescription. I will not be immune to that. Jim Bartlett and I met in July of 1956 at the very beginning of my residency. As chief resident and friend, he was to exert an influence on me and on my career, perhaps second only to that of John Romano, one of the leading educational figures of the 20th century and founding chairman of the department in Rochester. I remember early on, I expressed 3 concerns to Jim about my choice of psychiatry as a specialty. First, I bemoaned the loss of physical contact with patients. Did what I learned in medical school have anything to do with the care of psychiatric patients? He understood this and shared my feeling. Second, I was concerned about the grim prospects for our patients. At that time, it seemed to me as though we were not in a position to do much. Jim's answer was helpful then and has been all these 55 years. He indicated that psychiatrists' track record of helping patients compared favorably with other disciplines. 3, it happened that my first assignment was at what was then called the municipal hospital. The system was such that any patient assigned to us on the inpatient service became ours after discharge. I recall having been assigned a young woman with schizophrenia. Jim advised me to set up appointments for follow-up in the clinic, to monitor her medication and provide psychotherapy. I asked, "How do I do that?" He smiled and said, "Just talk to her." Well, that is what I have been doing ever since. The psychiatric scene in the mid-50s was a very far cry from what it is today. During our residency, approximately 80% of the time was devoted to learning about psychotherapy, 10% to the learning of diagnosis, which are summarized in DSM-1, Diagnostic and Statistical Manual 1, which could be learned in an afternoon. 10% of the time was devoted to somatic therapy, most prominently electroconvulsive therapy, ECT. Drugs available were countable on the fingers of one hand, perhaps with one finger chopped off. They included sedatives such as barbiturates, sleeping medications such as paraldehyde, first-generation major tranquilizers, and shortly after them, first-generation antidepressants. Imipramine was the first one. Today, the proportion of the time spent learning psychotherapy compared to that learning other things, including somatic therapy, is the reverse of what it was at that time. The field of psychiatry in the middle of the 20th century was very clearly bifurcated. As Hollingshead and Redlich wrote at that time, there were 2 types of psychiatrists: those who wore white coats and treated patients in hospitals, and those who wore sports jackets and treated patients with psychotherapy in offices. In 1986, the distinguished Harvard child psychiatrist Leon Eisenberg wrote a much-quoted paper whose essence is conveyed by the very elegant title, Mindless Psychiatry and Brainless Psychiatry. We shall return to the theme of bifurcation to see if it is still true. A brief history of the field. We have distributed to you, and we have extra sheets if you want to write on, fill in the blanks. Because what you see is what you get. All you're going to look at is me, and all you're going to hear is me. There's nothing on the screen. So if you want to write, feel free to, preferably in cursive. Okay. So a brief history of the field, if you're following the outline. Psychiatry's roots are wide and ancient. They include philosophy, religion, the law, education, sociology, psychology, and neuroscience. Psychiatry is indeed enriched by all these influences, but because of them, its boundaries are diffuse and its identity is uncertain. As a medical discipline, psychiatry is roughly 2 centuries old. The term psychiatry was coined by Johann Christian Ryle in 1808, almost exactly 200 years ago. Psychotherapy also has its ancient roots, but as a discipline, it is a little over a century old. The term psychotherapy was first used to describe a hypnosis-based suggestive treatment by 2 Dutchmen, Van Eyden and Van Rentgetem, in 1887. However, for all practical purposes, modern psychotherapy, as we know it, emerged from within the developing psychoanalytic movement early in the 20th century. After World War II, in our country, psychoanalysis became, in fact, the dominant mode of thinking about and treating patients, if they were not in a psychiatric hospital being treated with medications and ECT. The unseating of psychoanalysis from the throne of psychiatry came as a result of a revolution in the latter part of the 20th century. Many forces converged to produce this revolution. First came the community mental health movement, which reflected the radical thinking of the 1960s and 70s. The idea was that patients suffered from social neglect and prejudice and should be restored to society if they were to recover. For better or worse, the community mental health movement led to the closure or drastic downsizing of large state psychiatric hospitals. It led in time to a much shorter length of stay in inpatient facilities, going from months, which was true when I was a resident, to weeks in the 60s and 70s, and now to days. From another direction came the cognitive and behavioral movements in psychology. These started and developed separately, but eventually converged and coalesced into cognitive behavioral therapy, the famous CBT. Yet another influence was the rapid development of pharmacologic agents, and particularly the introduction of effective antipsychotics, antidepressants, and mood stabilizers. In the last 20 years, further progress has been achieved through the visualization of the active brain with the help of new radiologic techniques such as positron emission tomography, PET scanning, and functional magnetic resonance imaging, fMRI. The mapping of the human genome and genetic studies reveal the immense complexity of psychopathology genetics, but have yet to yield any clinical applications. Along with these, the somatic approaches to psychiatric illness continued unabated, starting with ECT back in the 30s, and more recently, light therapy, magnetic stimulation, and more recently still, the direct stimulation of the cingulate gyrus of the brain. Surgery on the brain to relieve psychiatric distress has a sorry history that is fortunately over. A small place remains for selective surgical interventions in a few cases of intractable obsessive-compulsive disorder. Now that it has become increasingly clear through recent studies that the brain is the agent and locus of all human experience, has psychiatry at last become a unified field? Many of the squabbles and arguments of the early and middle 20th century have subsided. There is widespread acknowledgement of the centrality of the brain. Its materiality is the one incontestable fact. But it is not yet possible, and may never be possible, to understand and deal with human experience entirely through reference to the brain. This is so because by its very nature, brain activity creates a new level of reality that is best understood in its own terms. I found this delightful and clever quote from a man called Emerson Pugh. If the human brain were so simple that we could understand it, we would be so simple that we wouldn't. In any event, we need the conceptual and the psychological. A simple metaphor may help. To understand play and appreciate music, it is not sufficient to understand how a piano works. When music fails or is discordant, the failure may be in the piano, its structure and tuning, or in the player. It could be in the music itself. Psychiatry is well placed to understand the piano and the music. What distinguishes psychiatry from other medical disciplines and sets it apart is the degree to which it is auditory. The rest of medicine is largely visual. Others treat what they see. We treat what we hear. The distinction is not trivial, because we humans are predominantly visual animals and trust and value what we see above all else. Seeing is believing. Even in the field of psychiatry, the major advances in recent decades have been in imaging the active brain. The auditory nature of psychiatry places it at a disadvantage. Perhaps again a metaphor might help. Localizing the source of a light and the source of a sound. A light source can be detected precisely by the eye at a great distance. A sound can only be localized if the ear is placed next to it. This brings us back to that most auditory of all disciplines, the practice of psychotherapy. Where does it stand today? It is in the nature of progress that older ideas and practices rarely die. They just shift to the side and the back of the stage. Sometimes they re-enter and occupy the center in surprising ways. Part of the decline in the dominance of psychoanalysis has been the lack of scientific evidence. In more recent decades, evidentiary support has emerged for various kinds of psychotherapy. Some of these have been refinements of traditional analysis, such as brief dynamic therapy, Gestalt therapy, interpersonal therapy, and transference-focused therapy. Some have been refinements of CBT, such as dialectical behavior therapy. With rare exceptions, studies show similar results with various approaches. So common is this that most commentators fall back on what they describe as common factors in all psychotherapy. These include the establishment and maintenance of the relationship, which probably is at the heart of the placebo effect, and the influence of education, modeling, and suggestion. They cut across. Other common elements in successful therapy are empathy, warmth, and affirmation. There are few instances of specific effective treatments in psychiatry. Perhaps the clearest examples are the use of stimulants for attention deficit and lithium for bipolar disorder. To a lesser extent, we may note the value of CBT and the SSRIs in obsessive compulsive disorder, and the use of dialectical behavior therapy in borderline personality disorder. For the most part, psychotherapeutic and somatic approaches work to varying degrees in non-specific ways, hence the very frequent off-label uses. This is not unique to psychiatry. The same pertains in other fields, particularly the use of antibiotics, anti-inflammatories, and steroids to treat many conditions in internal medicine. What of the shrinking use of psychotherapy in psychiatry? That's where we are on the outline. Despite the scientific support for psychotherapy, and a very important point, and the demonstration of changes in brain function that can be visualized under the influence of psychotherapy, changes identical to those produced by medication, most surveys show a shrinking role for psychotherapy and psychiatry. The recent survey by Mochabai and Olson compared the use of psychotherapy in 2004-05 to its use in 95-96. The result showed that 11% of psychiatrists provided psychotherapy for older patients in 2004-05 compared to 19% 8 years earlier. Further, 29% of outpatient visits involved psychotherapy compared with 44% 8 years earlier. People have challenged this study and the selection and said that they have somehow neglected to include evidences of greater use, but the idea is there. The reality is that most psychotherapy today is performed by non-psychiatrists. When it is combined with psychiatric treatment, the dominant mode is split therapy, wherein the psychiatrist provides medication and someone else, typically a psychologist or a social worker, provides the psychotherapy. Yet even in the face of declining use of psychotherapy in psychiatric practice, scientific studies and public surveys support the benefits of combining medication with therapy. A recent Consumer Reports survey of the readers showed adult respondents clearly derived greater help when they received medication combined with psychotherapy, preferably from the same person. The psychiatrist is the only medical specialist equipped to provide both services. The alternative is obviously the current practice of split therapy, which has its advantages, or medication without therapy, which is often all that the person can afford. To an unfortunate degree, the determinants of whether patients get psychotherapy from the psychiatrist are often financial. One can earn more in an hour of 3 20-minute med checks than an hour of combined therapy for one person. Those who nonetheless do provide combined therapy accept some loss of income in order to preserve the rewards of this combination for their patients and themselves. Two other possibilities for one person providing a combination treatment deserve mention. Psychologists prescribing medications and non-psychiatric physicians providing psychotherapy. Each has its advantages and limitations. Be that as it may, the decline in psychiatric psychotherapy, coinciding unfortunately with the controversial rise in drug company influence, has cast psychiatry in an increasingly negative light. The psychiatrist is often seen as a pill pusher. Today, psychiatry hops on one leg when it has two perfectly good ones. So let me come to psychotherapy for the present and the future. What then should psychotherapy be that can be provided under present and future conditions? It needs to be evidence-based, include the common factors mentioned earlier, be flexible and affordable. On occasion, it needs to be technically sophisticated, complex, and prolonged. For maximum efficiency, it needs to integrate the salient elements from the various schools. What are some of these? From traditional analytic therapy, the central role of transference needs to be retained, as every healer is wiser for being aware of it, allowing for it, and utilizing it. From Gestalt therapy comes the empty chair technique, the reenactment in the present of past experiences, and above all, the rehearsal of change. From CBT comes the use of reframing, the cognitive restructuring of reality and experience to create new feelings and behavior, and the effective use of exposure and response prevention to deal with phobias and obsessions. From dialectical behavior therapy, we find the powerful and paradoxical combination of acceptance and encouragement of change. From interpersonal therapy comes the productive emphasis on the person's relationship with significant others. From transactional analysis comes the easily grasped and applied concepts of parent, adult, child. Emotion-focused therapy opens the door to changing emotion with emotion. What might such therapy be called? Possible terms are eclectic, integrative, or humanistic. A particularly attractive label is existential. Partly because of its broad and varied meaning, the word existential allows for the incorporation of many approaches. It is the term favored by Jaspers and more recently by Irvin Yalom. What about the content of therapy? This comes down to dealing with three supreme and uniquely human challenges: authority, intimacy, and mortality. Authority is often neglected in therapy or comes up largely in relationship to conflict. Yet it is a pervasive and challenging theme throughout life. It is possible to trace the life story through the experience of authority. It brings up the themes of betrayal of trust through neglect and abuse. It opens the door to one of the three major affects we humans have, anger. And we've just had a presentation by Thomas Brunner here in Grand Rounds 2 weeks ago on anger. Anger is probably the most problematical affect for humans. Anger is a great motivator and a wretched guide. More positively, it can be channeled therapeutically in the service of rational assertiveness. Further, there are occasions for the therapeutic use of authority. Intimacy is frequently addressed in therapy. It has been richly explored by Bowlby in his developmental sequence of attachment throughout the life cycle. Intimacy is probably the most challenging of the three uniquely human themes. Intimacy is the source of the greatest satisfaction and the greatest pain. Problems with intimacy lie at the heart of the second major affect in therapy, that of sadness and related depression. Sexuality is one aspect of intimacy, but certainly not the only one. For most humans, sexuality involves two people, and therefore necessitates the harmonization of different needs and tastes. For those of us who address sexuality in therapy, whether with individuals or with couples, perhaps the hardest task is the reconciling of the needs and preferences of the partners. Another aspect of intimacy, and a source of much trouble, is its inverse relationship to authority. The greater the authority, the less the intimacy. The effort to compel intimacy through authority lies at the heart of much marital trouble. It also is the source of women's victimhood, historically and throughout many parts of the world to this day. Forced intimacy is a violation. Like authority, mortality is often neglected or avoided in therapy. As the ultimate fear, it is a door to the third major affect, anxiety. It brings into high relief matters of faith and the meaning of existence. Every serious consideration of it in therapy leads to growth. Irvin Yalom has written movingly about the issue of mortality in his 2008 book, Staring at the Sun. Considerations of mortality brings up the question of late-life psychotherapy and therapy with the seriously and mortally ill. In the past, the teaching was that psychotherapy, other than strictly supportive, was contraindicated for the elderly. After all, the argument went, insight and contemplation of change may be futile and perhaps discouraging when most of life is past. Wrong. Some of the best and most rewarding therapy can be done with the elderly. They bring the wisdom of their age and the perspective gained over time. They also bring a profound appreciation of the gift of life. They can and do learn and grow. That life should end well is a worthy aim, and most elderly people know it. I really enjoy working among them. On a calendar is the following quotation: "A sunny day redeems a dreary year." If you want challenge, work with adolescents. If you want gratitude, work with the elderly. Ultimately, therapy is a practical matter. Thrilling as discussion of these themes may be, people need and expect improvement in their lives when they come for help. This is why the role of the therapist is critical. Is the therapist a traditional doctor, counselor, educator, friend, caretaker, investigator, substitute parent, motivator, comforter? Obviously, the therapist can be and often is all of these and more. But perhaps the single most encompassing and appropriate role is that of coach. A good coach devotes skillful effort to the well-being and healthy growth of the person in training. And after all, we are all in training to lead our lives, utilizing a variety of techniques that suit the case and that change with changing circumstances. Final section. We're doing very well. We're doing good time here, guys. Relief is very soon. Rules of the road. As the practice of medicine allows the physician to touch and enter the human body, so does the practice of psychiatry allow the physician to touch and enter the human mind. The privilege of such closeness is governed by both moral and scientific discipline of the highest order. As John Romano used to say, the essence of psychotherapy is the disciplining of our capacity for human intimacy. A phrase worth repeating. The essence of psychotherapy is the disciplining of our capacity for human intimacy. A few rules of the road in therapy gathered over years of experience. 1. The relationship is first, foremost, and always. It can never be set aside. Resistance always defeats therapy. Carl Rogers found the basics of a good relationship in 3 elements: genuineness, accurate empathy, and unconditional positive regard. I suppose parenting too, huh? Among the common factors of therapy, the positive relationship is probably the most powerful. Jerome Frank has written about it in his book on Persuasion. It probably is the secret of the placebo, which alone has sustained and continues to sustain healing and treatment in the absence of scientific evidence. There's a great deal done out there for which there is no scientific evidence, but works because of this positive relationship. It also contributes materially to the success of evidence-based therapy. Because preserving the relationship is critical, conflict resolution becomes mandatory. Otherwise, therapy comes to a halt. There is magic in the genuine, unadorned apology. Sometimes it needs to be repeated. 2. Listen much, talk little, and judge rarely. The great difference between skillful therapists and novices is the proportion of listening to talking, and particularly giving advice. Inexperienced people rush in with talk and advice. Experienced people wait. 3, follow whenever possible, lead only if necessary. People go where they want to go. Therapy is best when it is a collaborative journey between willing partners. 4, inculcate the wisdom of the golden delay. In times of uncertainty, and especially much emotion, delay is invaluable. I often say to patients, remember, good ideas grow better with time. Only bad ideas decay with time. Teach the distinction between urgent and important. Emptying one's bladder may be urgent, but is rarely important. Sexuality is always important, but never urgent. There is a neural basis for this position, namely the tension between the prefrontal cortex, our executive brain, and the amygdala, our feeling brain. The amygdala is quick and often foolish. The prefrontal cortex is slow and often wise. 5, err on the side of kindness. This includes patience, perseverance, tolerance, and perhaps most important, choice of language. What a difference wording makes. Also, kindness leaves doors open to novel approaches. Errors of kindness may indeed be errors, but they are easier to live with and to sleep with than errors of unkindness. 3 things in human life are important. The first is to be kind. The second is to be kind. And the third is to be kind. William James. Be kind, for everyone you meet is fighting a hard battle. Plato. If you can't be kind, at least be vague. Judith Martin, Miss Manners. 6, err on the side of humanity. This addresses Roger's genuineness. Humanity includes thoughtful self-disclosure, physical contact such as handshake, touch, and the appropriate hug, and the answering of questions non-defensively. Not least is the therapeutic power of laughter. Victor Borge, the pianist and entertainer, said, laughter is the shortest distance between 2 people. 7, human relations, like the human eye, have a focal distance. As the eye sees best objects at a certain distance, so too people get along best at a certain distance. As with the eye, the distance changes with various objects and over time. Some people require and thrive on sustained, uninterrupted contact. Others find an annual Christmas note sufficient. The briefer the better. Problems arise, however, when 2 people do not agree on the right distance. The focal distance principle applies to most dyadic relationships, including therapy. 8, accept the reality that one is rarely a person's sole therapist. Significant others, acquaintances, and public figures exert equal, if not greater, influence. It has always seemed to me that therapy has worked best when I have an ally outside the room. Some may see other counselors or use unconventional and alternative therapies. In this age of the universal internet, many will find comfort in chat rooms, Facebooks, Google, and the rest. Extending respect to other helpers, professional and otherwise, is a way of respecting the patient. 9, maintain therapy as long as there is some evidence of benefit. This allows for and is consistent with interruptions, departures, and returns. Nothing dictates that therapy should be weekly or monthly. In fact, it may work best when the person feels the need for it. I routinely negotiate the next session with the patient by asking, when shall we meet again? There are those who need therapy and medication or both indefinitely. A question always worth raising with patients is this working? In the absence of any evidence of benefit, therapy should be terminated, but with as much care and kindness as possible. 10. Of all the mental health professionals, psychiatrists are uniquely placed to provide the practical benefits of combined treatment, medication and psychotherapy in the same session. This is their gift and their mission. By practicing combined therapy, they can manifest the much sought after unification of psychiatry. This is worth the effort and, if necessary, the sacrifice. People need and benefit from pharmacologic expertise and advances. They also need to talk. So in the end, Jim Bartlett was right. Just talk to her. Thank you. I'm delighted we finished in good time. If anybody wants to make a point or ask a question, feel free to do so. If not, you can all go home. Yeah, go please. Yeah.
Care to say something about the cultural match or lack of it?
Between therapist and patient. Very good point. Thank you for reminding me of that. Yeah, the cultural match. You know, it's like, you know, the fitting of the gears in a machine. Sometimes coming from an opposite culture, from a different culture, can be a benefit. And I have, being an immigrant, have found that. Just not being terribly familiar can allow for a certain kind of communication and certain things that otherwise would be taken for granted and set aside. On the face of it, you think it would be better to be from the same culture. And there are obviously strong arguments for that, knowing the background and the religion and the language and the habits and so on. But sometimes the unfamiliarity can be an advantage. Tell me about it. But you're right, the gears have got to mesh. Yeah, thank you for asking that. Yeah. Please.
You mentioned many good ideas, which I approve. But how are we going to carry this through in this culture that is so negative these days?
Sorry.
I say, how are we going to reestablish the way we used to be, you know, and it's very important relationship that a psychiatrist has with his patient in psychotherapy. But then the times have changed and so much dissension and craziness in the world.
Yeah, no, yeah.
Combating that.
Yeah, he's asking, you know, how can we do it in the face of these massive changes and great powers, powerful forces, not least being the economic. You know, it's amazing. You know, I think it comes down to those of us who believe in retaining psychotherapy as a major tool in our armamentarium, just doing it. Unfortunately, and I didn't have time to go into detail, some people have had to accept some sacrifice, kind of meeting the patient halfway, sometimes almost subsidizing the therapy. Now, you can't make a very prosperous living doing that, and I'm not suggesting that as a solution. But I think we need to keep that pilot lit, otherwise it will die out. I think there are people out there, and it's being written about. It hasn't died out, it has declined. Yeah. I don't have an easy answer. Yes, Ron. Yeah.
You mentioned a couple of times physical touch.
Yeah.
And obviously, as physicians, we learn how to do that from the beginning of our training. One of the problems that I see with psychologists prescribing is psychologists are going to have to touch their people to find out whether there's cognitive or not. I'm not sure they figured this out yet entirely. But I guess my question is really, we got a lot of this, you know, therapists sleeping with their patients, and so we have to be so careful. And I think for many years, people have pulled away from having anything that anybody could possibly think. And I remember Judd Marmor at one of the Evolution of Psychotherapy conferences saying about fathers, that these fathers who've become so afraid to touch their little girls have probably done much more damage to many little girls than the fathers who touched them inappropriately before. So I guess I'm wanting your thoughts about, obviously, that touch has huge power. And I'm not asking about boundary transgressions, although I know you know a lot about that. I'm really asking about the power of touch and how we, particularly as physicians, can harness that in our therapy in a way that's helpful to the patient.
Yeah, thank you very much. Excellent question. And in a sense, the answer to your question has been implied by your remarks. The whole issue of boundaries and the very helpful distinction being made between boundary crossings and boundary violations. In other words, are you breaking the rules innocently but in the service of the therapy and with good result? Or are you doing it foolishly or maliciously and leading to harm? And obviously, I mean, what we spoke about regarding touch also applies to disclosure and other things, and giving somebody a ride and loaning of money. And you can think of many examples of doing things with patients that are against the rule. But I have found, over half a century of practice in psychiatry, the touch at times is invaluable. There are moments when people need that consolation, are in such great distress. They just can only express themselves and feel that closure, if you will, if they can have a hug. I've done it, and that's why I deliberately put it there. I confess it, I admit it. I've never had reason to regret it. Is there always a judgment and always the issue of how it's done? And I'm so glad you said about the phobia we have developed in this country of touch. We have become phobic about physical contact. We sexualize it, and next we criminalize it. And God forbid that it should be the same sex. That's even worse. Don't touch, you don't ask. So I deliberately injected that, and I appreciate you emphasizing it, Ron. Please,
I was just curious as to why psychotherapy is saved for the latter years of residency.
I beg your pardon?
I was wondering why psychotherapy is generally saved for more of the latter years of residency. We start getting it, I think, the second half of our second year.
Yeah.
Why is it not introduced earlier on?
Yeah. Did you all hear the question, why is psychotherapy in the training put in the latter part of the residency? That was not true in my day. You remember? Jim Bartlett said, talk to her. I was a week into the inpatient service in July of 1956. So that's not always been true. I don't know if it's universally true. I think it has to do, it's not philosophic. We have talked about it, and you may want to remark on that, Richard. Philosophically, in our department, we don't like that. We'd like it to be... Go ahead, make a comment on it, please.
Well, we actually have made some changes, in the past year, actually, along these lines. We have created a course for PGY1 residents on interviewing. I don't know if you actually had the chance to attend that. Yeah. So that is, basic communication skills and basic psychotherapy skills are being taught now in the PGY1 year. We also have year-long courses in the PGY2 year. We created a new course that is really addressing biological, psychological, and social factors in basic science, in depth, 40 sessions.
Right.
So it's all geared toward that integrated vision that John's talking about.
But in truth, the reality is, however, the truth is the way it is, because I supervise ones and twos. People hopping around between the VA and UPHH South Campus and coming back on night call and day call and on medicine and on neurology. It's very, very hard. I mean, when I have tried to do it, it's been a rare event to be able to find the patient and the room and the time and the supervisory hour. So there are practical aspects of the structure of our residency that work against it. But it is not our preference. It's like we're struggling with it.
Could I just follow up on what
go ahead, Ron.
You referred to it as an interviewing course, and of course it's a people skills kind of thing. And one might think, well, that's not really therapy. But I want to argue it is really therapy, and many of these common factors that you were talking about, many of what Rogers is talking about is right there in that course. And I'm reminded of, 3 or 4 years ago, we had a little interaction between one of the residents and one of the group members that I was supervising. and let's say the resident didn't handle it as well as I would have hoped. And the patient turns to her and says, "Don't they teach you guys minimal therapeutic responding?" And I'm sitting in my office saying, "No." but now we're beginning to. And I think that it's so important that we're doing that, and how much that is the foundation for what comes later.
Yeah, my argument is that it's only 1 hour. It's only 1 hour a week, though. I feel like. No, you agree, but never mind. I just
Great.
wish you get more.
Question back there, please.
What about residents' own therapy? Because I think back in the day, it used to be forced for us to get therapies. And is it a political issue that you can't force people to get therapy?
Yeah, I doubt. I don't know if anybody has ever been forced. In
Not
certain,
forced, but part of the
well,
structure.
yeah, part of the expectation. In certain programs, particularly in large metropolitan centers, mostly on the East Coast, I remember during my day and later, it was almost, it went without saying that part of their training residents went into therapy. It was strongly encouraged, occasionally assisted, like given the time and maybe some financial assistance and somebody to go to. Today, certainly residents are free to, but I don't think there's any pressure. I don't know if there's any discouragement on the other hand. I don't know. I don't know. Do we discourage people today? If anybody wants to get help? We don't provide for it. We don't push it. Yeah. Do you have any thought about it, Richard?
But I think, John, back in the day, the expectation was that you'd be in psychoanalysis. It wasn't going into personal therapy. At least that's the way it was when I was a resident
Yeah.
at the University of Washington. And I think I was the only resident in the program who didn't go with that.
Yeah. So in you, yeah.
They gave me a faculty.
Yeah.
But it was psychoanalysis as opposed to personal psychotherapy, which was always sort of a separate. But once psychoanalysis faded, I'm assuming that kind of dropped out.
Thank you, Patrick. Yeah. Go ahead, Richard.
I still think it would be desirable for residents to go into psychotherapy. I think one of the problems is now that even as PGY3 residents only have 2 or 3 psychotherapy cases, and so we're kind of asking them to go into personal therapy themselves so that they can perfect their skills as a therapist, but they don't really have that many patients that they're able to treat. I think that's the crux of the dilemma right now.
And part of the vicious cycle, when they enter practice, it's not going to be a large part, which weakens it. I mean, you know, there is a vicious cycle here. Yeah, yeah. Please go ahead, Cassandra.
It was my experience when I was interviewing at different programs all across the West Coast that this is one of the few programs that doesn't offer or encourage therapy.
You heard encouragement of therapy in other programs.
Absolutely, yes.
Yeah. Okay.
But I think it's still present. It just depends on who.
Yeah. Okay.
Well, I will certainly say that I have personally encouraged every resident I've gotten the chance to go into therapy. I think therapy has been incredibly helpful for me. I would not be the therapist that I am today had I not had that personal therapy. And also even not just talking about psychoanalysis, although it's nice to be able to call it a training analysis and then I don't have any stigma attached to it. Right? And of course there's the insurance issue.
Yeah,
but I think that the residency does have a list of people who are willing to give special rates to residents.
I don't know.
And I think it's also true even with CBT, right? You want to learn CBT? Well, do some thought records yourself, right? I mean, these techniques too. It's not just the, in-depth psychoanalysis that you need to understand something about, but see this, and when you can see it working yourself, it gives you a confidence. Even if you went out and you're prescribing meds, but I can say, psychotherapy would really work for you because I've felt this myself, right? Then your referrals make more sense even if you're not treating one.
Thank you, Ron. Please.
I think a lot of the expectations are based on, I don't know how it was 20 or 30 years ago or beyond that, but these board-style questions, the expectations of an instant answer, it's either 1 out of 4 choices. I think that's become, and the idea of psychiatry becoming part of the medicinal approach where things are, there's a very finite number of possibilities, and the answer should be given very, very fast. I think that, we have to take these board questions, and when all you're doing is studying about medications and pharmacotherapy, and you can't really take a multiple choice question exam for actual psychotherapy, that starts to change the expectations.
It's always kind of silly and so on.
Can I talk? Yeah, I can be talking like it. But I think there's a danger in forgetting that what you said is also supposed to apply to cardiology, but it doesn't. There are only a few choices, and it should be clear how you treat people. But we all know people that have cardiological problems. What happens? They go and they get fixed the first time, correct diagnosis, treatment done. It doesn't happen there, and yet we somehow compare psychiatry to this idealized version of the rest of medicine, which is wrong.
Yeah, true. There are debates to this day about stents and the medicated and the non-medicated stents and intervention versus non. Any other comment or question? Please, yeah.
The visual auditory paradigm you mentioned earlier reminds me of the first month or two of residency when Dr. Brosen took me down into the library, and I labored looking at tapes of patients being interviewed. Turned off the sound and trained and drilled me in terms of the non-verbal aspects of communication, which can be very powerful and often underlooked.
Indeed. And we don't pay enough and he used to call it kinesics and so. Yeah, he was right to emphasize that, and we don't pay enough attention, and yet it's so pervasive and so important. The non-verbal, I couldn't agree more. The way we look, the way we communicate, the eye contact. We could spend an hour just talking about the eye as a therapeutic tool. And people who don't look at you, it's kind of very discouraging. Whatever they say. Any other comment or question, please?
Sort of a question along those lines. So with telemedicine and telepsych, and then creating the right distance, and what are the advantages to the sort of intimacy or lack of intimacy, or the distance or the change of focus that happens with telepsych? And what do you think about its future?
Yeah, the nice thing about telepsychiatry is that you can reach people far and wide, and we do it in our department. Mostly it's evaluative diagnostic, and suggesting medications. I don't know. Ron, you've done telepsychiatry, but do you do psychotherapy? Yeah. Well, you can tell him. I haven't done it.
I think it works fine. I've even done couples therapy where, I just get both of them there, and in many ways it's like being in the same room. So I think it works pretty well. And one interesting thing, and I don't remember the details, but someone here, Dr. Cruz, who's here, looked at when you add a little noise and make it sort of fuzzier, like when you blur out an image, it actually improved in some ways the thing rather than too much detail. So that there's something about the gist that can, I think, come through in this case. And, it is a different sense of intimacy. You won't get a hug in telemedicine, so that's true. And yet, for some people, it also probably provides them, with a certain safety of being able to talk. One of the places that I did telemedicine with was to the city, and many of the people who worked in the hospital didn't want to go see a provider in the hospital because they were worried about, records and all that sort of stuff. They liked the idea that the only person who knew what they were talking about was in Tucson. So, it can work in lots of different ways. But I think it certainly can work.
Yeah. That's a very good answer, based on experience. Any other comment or question? Yes, please. Yes, Pam.
When you talked about intimacy and authority, and you said that that women have been victimized across the world through violations of intimacy, do you see intimacy and authority as gender related?
Of course. I mean, they're absolutely, Now, we do know, that our culture and throughout the world, the dominance of males over females, There was perhaps an ancient time in the history of humans when, there was the mother goddess and women led everything. But throughout recorded history, there's no question that men have run the show, dominated women, exploited them, and violated them. And the reason I tied it up to the intimacy, because that's one area that's so easily destroyed by compulsion, by the use of authority. Often the authority is supported by, presumably by reference to religion. You know, that it gets contaminated with that issue too. And it becomes like, this is the proper thing to do, it's my right, you've got to do it, and so on. And I think the first thing that flies out is the spontaneity and pleasure of sexuality when compulsion is brought into it, or obligation. And the compulsion doesn't have to be physical. I mean, there are all kinds of ways to exert power over other people, including resources, attention, and the invocation of certain social principles. It's your duty. Yeah?
I guess I was thinking, though, when we were talking about different cultures, coming from a Jewish home where there was a matriarchal presence, and that presence seemed to have their own sort of authority and also their own, issues with anger.
Yeah.
It's the reverse sometimes with different cultures, where the authority is actually with the female, and the issues and the intimacy might be with the male who's depressed.
Sure. Yeah, I think there are exceptions here and there, but I was talking about the dominant mode. If you think about the world in general, it is true, I think, if you think about the world, women have yet to achieve equality with men. It isn't accomplished, not yet, if we look at it globally. Any other comments? Well, thank you very much for your attention.